Hey, you guys, so sorry for the delay. Welcome to the EMS Academy. For those who I haven't met, and there are a lot of new names. Welcome, I'm Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County, and have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, I know that Dr. Sago is also with us on the training tonight. On behalf of the EMS office, Captain Nats, the EMS Training Academy staff, and Captain Stewart, thanks for what you guys do every day. Thanks for joining us here tonight. Big shout out for Ashley Brooks. Ashley is a volunteer at Pikesville. She provided a link for us sorry, I'm managing the platform at the same time. A link for your CMEs, MIM CEUs. So later in this training, I will post a link in the chat. Click the link, fill out some basic information, click enter, and you will be able to get your MIM CEUs. If you have any questions about MIM CEUs, certificates of participation, finding your past trainings in the MIM CEU portal, please hang on till after this training. I'm happy to hang out with you and see if I can answer your questions to make sure you have your questions answered around your CMEs. Yeah, so super delighted and honored tonight to have with us Dr. Alistair Kent. Dr. Kent has been with us a couple of times now, providing a variety of trauma-based topics that are available in the public domain on the EMS Academy website. Dr. Kent is a trauma surgeon at the Johns Hopkins Hospital and the Johns Hopkins Bayview Medical Center. Dr. Kent's area of clinical expertise include general surgery, trauma, acute care surgery, surgical critical care, and surgical care of medically fragile patients. Dr. Kent is an accomplished educator and researcher. Dr. Kent's research interests include studies of healthcare delivery systems, healthcare economics, geographic analysis, trauma care, and systems of care for patients with life-threatening or time-sensitive illness. On a more personal note, I've had an opportunity to work with Dr. Kent for probably close to a decade now in the ICU as well as in the operating room. He is exceedingly well loved, respected, and appreciated by his peers and colleagues, me included. Alistair, thanks for being with us tonight, and thanks for what you do. We appreciate you.
Thanks, Sean. That was a very generous introduction. I will go ahead and get my screen shared here. And get my presentation started. All right. I think everyone should be able to see the slides up at this point.
Yeah, looks good.
All right, great. So as Sean said, I'm Alistair Kent. I'm a trauma surgeon and intensivist at Johns Hopkins. This is where I work, or sort of where I work. I work over to the right where you can't really see behind the building. I think they like to keep me in the backside there.
Alistair,
So
I do think you're on speaker view and folks can see the slide in your next slide. So I wonder if presentation view.
Yeah. Let
make
me
the slide a little bigger for people.
how's that? Let me move the thing out of the way.
Not quite yet. Still seeing the next slide.
And there. How's that?
Try going to, there you go. Perfect. Thank you.
Better?
Yep.
Let me minimize that. Okay. So that way you don't get to see the spoilers. This is a similar title to a lecture I've given before in a couple of different venues that you guys may have seen from an EMS standpoint, both in the Pikesville department and then at Ocean City conferences. This particular talk is updated a bit. For one, we have a lot of new data since the last time I gave this talk and experience with these. And then I wanted to shift this a little bit to more something you could take away. So the first part of this is going to be a little bit of basics about how bullets work. And then some big picture epidemiology, statistics, that kind of thing about gunshot injuries. That's the sort of snoozy part. And then the clinical takeaways, and that's where I want everybody to really focus. So there's 4 things I'm going to talk about. They will be listed multiple times. If you take away nothing else, take away those 4 things. So there we go. Disclaimers. all the pictures I'm showing are either mine or what I believe to be public domain. If they are not, please contact me and I will remedy that. I'm not a former military police service person, but I've been shooting guns extensively since I was 4, and grew up in that environment in a very rural area, which has kind of been an interesting and informative approach to what I do now, which is take care of people that get shot a lot, and we have quite a bit of let's say business in Baltimore. I also have degrees in math, chemistry, and emphasis in physics, and enjoy some of that again. So there might be some numbers and pun intended trigger warnings. So my social life aside, starting with guns and bullets. So bullets, and I understand there's probably a lot of you that know this at least as well as I do. But oftentimes when I give this lecture, there's a lot of heterogeneous knowledge of it, or there's anecdotal knowledge and a lot about pieces, but maybe not other pieces. So I'm going to go through some basics, try to get everybody on the same page. A bullet is really just a way of taking the energy that's chemically contained in black powder or some other substance, and then transferring it to mechanical injury or mechanical energy, which is carried in the bullet and then delivered into a target, which is a person or an animal or just a piece of paper. You can see the general shape of it here. Energy, which is all again from the expansion of gas after burning the powder. And again, the powder has its own oxidizer in it, so it burns in a slightly different way than what like wood burns. But the expansion there is related to the heat of release or heat of formation of the new gas, and then so the bullet goes out proportional to that. That can all be very precisely calculated, and so you can make different powders for different kinds of guns and different situations. The key to note here is that, if you take away nothing else from the math part, the velocity squared or the energy varies with the square of the velocity rather than just the velocity, whereas it varies with a constant value of the mass. And so if you double the mass, then you double the energy. But if you double the velocity, you quadruple the energy. And so this becomes important when we talk about things like different calibers and different muzzle velocities, and how can small bullets do more damage than big bullets, and things of that nature. Again, gunpowder is the energy source, bullet size is the mass. Caliber can correlate with a bullet mass, but it doesn't always. It just gives you an approximation. So again, caliber is just the width of the bullet, but it doesn't tell you about the length. And so the volume is really where you get the mass. The other things, so barrel length actually makes quite a bit of a difference. So for any given cartridge, the longer the barrel, the higher the energy that's going to happen. And that's because the amount of pressure that is delivered to the back of the bullet has a longer time to add energy to the bullet before it equalizes with the atmosphere, meaning when it comes out of the end of the barrel. So this is why longer barrel guns are both more accurate and higher power than their respective short barrel cousins, even if they use the same cartridge. A very simplistic picture here. So, and maybe just to put it into context. So you can see this is, a very rudimentary gun drawing. It's a little cannon, and there's a ball inside, and there's some energy from an explosive. What's important to note is that the gun goes back also, as well as the bullet going forward. And Isaac Newton tells us that every action has an equal and opposite reaction. That's 100% true in this case. And so what that really means is that the energy coming out in the bullet is exactly the same as the energy you feel in the recoil. And so for the rest of the talk, I want you to think about bullets as really just being a packet of energy that is then delivered from your shoulder that's holding the bullet or hand, as the case may be, into a more focused area of another person. And so this really naturally leads into the discussion of things like stopping power, and that is a common term of people that like guns a lot or use them, but maybe with the incomplete understanding of how they work. So one classic example of this is that, the 45 caliber Colt automatic was supposedly issued to the troops to stop a charging horse back when horses were still used in cavalry charges and with some frequency. This also came up in the late 70s, 80s, I believe, when the 38 special and then subsequently 9mm were replaced in some police departments with the 10mm, which is the same caliber, but a much more powerful round than the 40 caliber for the purposes of applying more energy and having a heavy caliber. It turned out this was actually harder to shoot, and so people went away from this largely. Realistically, when you look at muzzle energies and the amount of energy delivered, there's not a whole lot of difference between even small and large caliber guns. And I'll show you the actual numbers on that here in a subsequent slide. So just kind of keep this in mind as we look through what the bullets actually do. You can get, the 10mm round is a very high energy handgun round. Rifle rounds are an order of magnitude higher energy than a typical handgun round. Higher energy loads, 44 Magnum extended rounds exist. These kinds of things, SP loads that have higher energy, but still these are within probably 50% of the energy, or maybe double the energy, but not orders of magnitude higher than regular rounds that you would just buy for target practice. So terminal ballistics is really the other piece of this. What happens to the bullet after it hits the target? How is that energy delivered and focused? The other piece of is not just what energy arrives, but what energy is deposited in the target before the bullet exits. And so is that a bullet that passes through the target leaving very little of its energy behind, or is that a bullet that delivers all of its energy in a focused way and causes a lot of damage to an organ that's important? Aiming is also important. So if you put a lot of damage into a non-vital or non-mobility centric area, it probably doesn't matter that much. A gunshot through the right lung is often, very well tolerated, even with a high energy bullet, whereas a gunshot through the heart, even with a small bullet, is not well tolerated. Other things that come into account. So the shape of the actual bullet. And so every type of gun has multiple types of ammunition. Again, the amounts of powder can be different for the same bullet type, but then the bullet type, the thing that actually flies, can be different itself. And I think there's a slide here on the next thing that shows some examples of this. This comes into play with, how is that energy transfer? It has to do with collision mechanics, which we'll show some more examples of, elastic and inelastic concepts, differences in the type of material and how it reacts when it gets hit with something, really impacts how that energy is applied. Classic example of this, hollow point versus full jackets. There's different types of these things. There's actually more advanced types of energy delivery shapes that are available in military rounds that are not in civilian. And we may look at a couple of those. These are 22 long rifle, I believe, that show the different relative tips, or actually these may be 38s. But you can see there's a range between, an all lead uncoated tip with a copper jacketed full jacket tip, a soft nose tip, a hollow point, other types of hollow points that are designed to fragment, frangible bullets that basically are designed to fragment on soft targets so that they don't pass through walls. They're used in law enforcement frequently. And then the shot shell cartridge, which is basically a little tiny shotgun shell that works in a otherwise normal handgun. Examples of hollow points and what they look like. You can see that the left picture shows the, let me sort of put my pointer on it. It shows the full jacket here, the hollow point here, and then these are examples of different sorts of hollow points and how they actually change shape when they hit tissue. Or I think this was a water jug that they used in this particular experiment. To put it in context, a shotgun is similar in structure, and so there's some analogous things. So there's the powder, which supplies all the energy. The main differences in a shotgun is that rather than having a single core, projectile, there's a group of projectiles, which is the shot. It can be different sizes. It can be a slug, which is one piece, large caliber shot, or smaller shot. Here's some just differences in size. And again, the bigger ones have more powder in them. You can also have longer shells that have more powder than the shorter ones, or higher energy loads for different purposes. And there are many, many varieties of these. Gauge, if anyone is curious, is really just a measure of how much or the size of the pellets, and not so much how much is in there. So they typically will give you a gauge, which gives you the size of the canister, and the size of the ball that would fit in that diameter of a barrel, and the number of those balls that would equal a pound. So it's a little bit of a backwards way of thinking about it. So the higher the gauge, the smaller the diameter of the ball, but it doesn't tell you how much is actually in the shell. It doesn't tell you the diameter of the shot that's actually in the shell. It's really just a convoluted way of saying how big a round is the shell. So my Bit Defender is advertising. All right. And just some examples of what those different shells look like. So on the left side here, you see this is a bird shot. It's multiple small pellets that's designed to hit a bird in flight. They don't have to be very big, but the spread is important to take down fast moving game. Buckshot, on the other hand, is bigger, again, for bigger targets. That is needs a heavier. And then different spread patterns between the ends of the gun can be tapered, what we call a choke, to affect how the shell spreads out over the distance. And you can see the top there is no choke, and then the full choke, or the concentrated choke at the bottom, keeps the pellets together in a tighter group for longer. Another example of shot sizes. And you have the slug, which is the single pellet there on the end, and then various sizes all the way down. Okay, so now we have a background on bullets and different types and that kind of thing. So let's take a little detour, and we're going to talk about gunshot injuries. So this is Baltimore's murders so far, and this is city of Baltimore. I realize we're talking or omitting the ones that happen outside of the actual city limits, but just to give you an example of where we are actually at, and these are all homicides. So a couple of wordy slides, and we'll get through these kind of quick. So 32,000 people died, 67,000 people are injured. This is actually a little bit higher now than from the 2016 data. No surprises, I think, in terms of some of the other patterns, things we hear all the time. The men, ethnic minorities, young Americans are disproportionately affected by homicide. Older Americans, again, particularly men, are affected by suicide. Billions are lost to medical and work costs. The rates of firearm violence went down a little bit. In the 90s, they actually went back up in 2020. Suicides also have continued to increase at modest levels. We'll see.
Hey, Alistair, any thoughts as to why they went down in the 90s?
So some of it had to do with the crime legislation and things that was passed. Some had to do with LA gang riots and then the subsequent end of those. Another sort of commentary that gets talked about a lot is the assault weapons ban, which we can talk about in a little more depth if we want. I want to avoid this being a big gun policy talk, but we can get into that. What did it mean? There is a lot of talk now about trying to reinvigorate the assault weapons ban and whether that will or what effects that should have. I think generally people agree that it will reduce certain amounts of gun deaths, but which ones they do and how many, I think it is. I think there's a wider opinion on that.
Thanks.
So all violent deaths, most of these end up being guns. So a lot of them are suicides. homicides, and then, other undetermined or unintentional sorts of things. We'll look at these numbers in graphs here in a second, so they're a little more clear. This is sort of, for reference later if anyone is particularly interested. So 4 main categories of shooting deaths. Again, suicide is the most common. Violence, including homicide, is less. These numbers are actually closer now than they were, and you'll see that up on the next slide or two. Mass shootings, again, increasing in frequency, but still remain about 1% of all homicides. So again, while there is a certainly a substantial increase in this over time, again, we'll look at this data also. The total numbers actually remain quite modest in terms of the numbers of deaths that actually occur because of them. Unintentional is similar. Hunting, accidental related deaths related to guns are pretty small in terms of the whole thing. It actually appears to be decreasing over time, and does appear to be related to gun ownership and gun laws in different states, though these studies are not well controlled, and it can be a little bit difficult to parse out, which thing is affecting what, though there do seem to be real statistical effects. All right, lots of words, now some sort of condensed context. So gun deaths are going up, gun injuries are going up. Again, 2020 saw a big spike. We also saw big spikes in domestic violence and stabbings and everything else when everyone was packed in with quarantine. Suicide remains the most common gun death, but homicides are increasing. Suicide trends increasing as well across the country. Here's some numbers for US and then Baltimore specifically. You'll notice both with homicides and suicides, we have a pretty substantial share of the burden. And here's really kind of like the meat of the 2020 spike. So suicides went up, but homicides went up substantially. And if you look at this in the context of historical rates, they're not as high as they were in the 70s. Or even the early 90s, but they are the highest they've been in quite a while. You can say this is actually somewhat independent of the assault ban legislation that we had, and it was really 2020 before this. When you look at total gun deaths, including suicides and homicides, actually picked up. Handguns, again, by far the most common gun crime and suicide weapon. Here's numbers for just murders. You can see handguns are there. Rifles is where you will see the things that are determined to be assault rifles. It's about 2.5%. Shotguns about 1.5%. And then the unknown is just probably distributed similarly to these other numbers. And then you can see other knives and other things. And these are interesting statistics if you look at this in different countries as well in terms of what weapon is used for violence. Here is again similar data, but in more precise format that might be a little bit easier to read depending on how you like to perceive information. But again, handguns most common, undetermined firearm, and then rifles, shotguns, other guns less common. Suicide numbers. So this is suicide for men by age category, and you can see that especially older men will choose firearms and be successful at it. And these are all successful suicides. If you look at attempts, handguns are actually less common. This is numbers for women, slightly lower numbers, but still substantial, especially when you look at total numbers of attempts versus fatal attempts. And then the question always comes up, what about assault rifles? So this is incidents of mass shootings in one view. We'll look at another one here in a second that's maybe a little more informative. This shows number of fatalities and the number of incidents. So you can see there is a steady increase in the number of incidents, but a disproportionate increase, or what you might say is a power relationship between the incidents and fatalities. So, the gap that you see between late 90s and late 2000s is when you see the assault weapons ban. And so this is what fuels a lot of the discussion of, is that helping? And it clearly reduces the amount of people that die in mass shootings. And it reduces it by something like 40% if you look at different studies. So you have average numbers of people killed in mass shootings is like between around 5.5 versus about 3.5. And again, this is selected for mass shootings, depending on if it's more than 2 or more than 3, it changes those numbers a little bit. Then this is, I think, a 2016 number, so it's a little older. So, and these numbers are going to be higher now. Just again, because the number of mass shootings is substantially higher. But the top graph shows assault weapon sales, and then the bottom shows the number of guns used, or murder victims by guns used. And you can see the rifles were, again, a small part. And these numbers are similar to what numbers we saw on the previous slides. Here's another way to look at it. Mass shootings by weapons mix, actually all the way back to 1966. And so the darker red the color, the farther back it is, the more blue, the more current, and the data stops to 2018. And so you can see handguns alone account for the most even mass shootings, rifle, and then rifle handgun, and then shotgun rifle handgun, which are sort of in these places here, are some more kind of where you might expect to see those assault weapon deaths. And you can see there's some big ones, right? Orlando, Las Vegas, Sandy Hook, and then Columbine, McDonald's, or farther back. And, compared to the ones with the handguns, you don't see quite as many of these, wide categories. And so there probably is an effect here, which is not surprising. Let's say the ease of delivering high energy rounds in an accurate way, the assault weapons are designed to do that. Here's another look at the mass shootings. And you can see the locations are diverse sort of across the board, but the numbers are substantially increased in an exponential sort of way. So that's sort of what we're dealing with. And again, what you're going to see mostly is handguns. In Baltimore, you're going to see multiple injuries with handguns. Occasionally, we see other things: rifles, specialty ammunition, occasionally assault rifles. But for the majority, you're getting handguns with the types of ammo and energies that they deliver. This is the Bayview Trauma Bay. So here's your takeaway. So here's where to pay attention and to when you see a takeaway, remember the things that are attached to it and write it down. If you don't remember anything else, remember all of these, and especially the last one in the context of EMS, time saved is life saved. The faster you get them to us, the faster we can get them to surgery, the faster we can stop the bleeding, and the better that they will do. So small holes can hide big injuries. Some different kinds of bullet holes. So here's one on the hand. And I will qualify that this review of bullet holes is not intended as formal forensics training. Please don't rely on this for that. It's more of an interest, and again, to kind of give you some pre-exposure to what you might see if you haven't seen it yet. Oftentimes these can be seen in someone that's putting their hand up to when they see a person raising a gun at them. This particular patient, I believe, was then hit subsequently in the shoulder behind. But you see on the front side, there's a relatively small piece. Expansion of the bullet releases, and then on the back side, you have a larger. This is classic, and it's also often wrong. So it's very difficult in real life to tell the difference between entrance and exit wounds. Medically, we don't try to distinguish that, especially in the setting of multiple injuries. It's the paths of the bullets can be very convoluted, and it's not particularly instructive to understand which is the entrance and exit from our perspective. But, from a forensics perspective, that's a different story. And again, that's why there are special training forensics people that make these decisions. Similarly, close range wounds, you might see something like this with bullet stippling, and that's from unburned powder that hits the skin on that lower picture here. And then this is a contact wound. So this is the flash coming out the barrel. This is the hot barrel and the end of the gun adjacent to the wound. So there's slight difference in close range that you might see. Again, there are exceptions to this, and this is not prescriptive. Shrapnel injuries, and fortunately, we don't see a lot of this. I think I've seen a couple, maybe 3 since I've been in practice here. Blast injuries where you see things like this. This is an intentional shrapnel injury. The ones we see are often accidental in terms of industrial accidents, but they can have both blunt and penetrating type trauma and multiple penetrating wounds with diffuse blunt injury. And so they can be very complex to manage. Shotgun injuries can present similarly depending on, again, the ammo, the range, the power, the load. And the closer the person is to the explosion, it increases the damage. And so it's a volume relationship. It varies with the power of the distance. And so like a person that is twice as far away will have a markedly decreased exposure to the blast wave than somebody that is half the distance. Often the objects move in funny ways as well. So talking about energy of bullets, and we're going to get into this a little more. So here's just sort of a visceral example of what you might see. And this is a bullet with relatively little energy here that pokes a hole and again in the skull, goes through the brain, versus a bullet with high energy that has caused a substantial amount of cavitary damage and then pass through to the other side. Cavitation effects are something that happens when you have a wake behind a moving object in a fluid. And when you think about the speed that bullets are moving, almost everything is treated like a fluid, with the exception of very rigid materials. And so passing through tissue, things deform. And there is some subtlety to this. So as oftentimes we'll look at ballistic gels, and we will later here in this little segment, but the ballistic gels can oversimplify to a large degree what's actually happening in terms of damage to the tissue. Oftentimes you see what you see in this particular picture, and it describes a temporary cavity and a permanent cavity. The cavity is not the end all be all of what damage is caused. It has a lot to do with what area of the body it's in. But this is a good way to at least start to understand how a bullet behaves and what happens to the energy delivery as it moves through tissue. And so you can see at the first, the bullet is giving up very little energy, but then begins to tumble, creating this large cavity. A fragment comes off, and then the larger fragment comes this way. But at this point, the energy has been delivered, and now it's sort of passing at a lower speed through the tissue before it finally stops. So the shockwave itself can stretch and damage tissue in excess of what the actual bullet that maybe is poked a hole appeared or that looks like. This can apply to any projectile, but the faster the bullet is going, the more effects like this that you're going to see. High velocity projectiles, and this is like the really rifles and blast injury type things. Very few pistols have enough energy, even magnum loads, to cause cavitary damage in this sort of way. But occasionally we do see it, especially with tumbling projectiles and that kind of thing. Another example, so this is a classic Google picture that I use in almost every trauma talk because it's wrong in so many ways in terms of the way that there's a retractor that's on the wrong way, and the catheters, they have the heart aren't clamped, and so you can see blood dripping out the end. But what it does show is a relatively low energy gunshot to the heart. And so there's a hole poked here and a hole poked here, and they've got control of it with a clamp. In contrast to this, high energy, this is a patient that I had 3-ish years ago. who was sitting in a barbershop chair, and somebody walked in and shot him with a close range shotgun with a slug. And what my hands there are holding is actually the heart that is split open along the end. This patient actually came in with a quote unquote pulse. And we didn't discover the amount of injury.
I don't know. Never really thought about it. Why? Just thoughts, thinking about options.
Oh, sure. Yeah.
When it comes to seriously stop shit.
So it's just for some orientation. Left and right ventricle are there and there. The valves are there and there. And again, this is the result of the wake of the bullet more than the size of the bullet. To put some numbers on this. So this is muzzle energy, and I apologize, there's a little bit of a separation in terms of units here. You see joules on the left side here and foot pounds here. A foot pound is 1.36 joules. And, if you're interested in particular conversions, I can get those to you. You see down on the lower end, 22, the little plinker gun is 130 foot pounds. And then you look at a assault rifle load, 1200, something like that. And then all the way up to hunting rifles, which are, again, about double what an assault rifle is. And then, high energy sniper rifle is about an order of magnitude higher than something like a 40 Smith & Wesson or a 45 or even a 9mm. You can see these are all within 20-25% of each other. And then pistol energy down on the bottom here. You can see a magnum load here on the end. This is a 357. There are higher energy pistol loads, but most of what you see are going to be in this range of 300 to 500 foot pounds, or and 400 to 600 megajoule or joules rather. And then, the way that these are set up, the actual bullets look like these. The rifle rounds on the top, or assault rifle rounds. So these shorter ones, you can see the bullet length can be quite different. Even in all of these are 7.62 diameter or caliber bullets. Obviously, this one has much more mass than the one on the end. The 223 is similar to a 5.56 NATO. It's an assault rifle round like an M16 or AR-15, though that can be chambered in different rounds as well. And a 308 Winchester is a classic hunting rifle, sometimes sniper rifle round. Pistol rounds here, you can see there's a slightly different format to them. They tend to be straight. They tend to have a larger bullet to powder sort of ratio. And then a larger hunting and the Lapua sniper type rifle is down here. 300 Win Mag. These are all the higher power end rifles. And you can see the casing is quite large to hold extra powder, and then the bullet kind of crimped on the end. And then just the differences here again for reference, mostly that handguns tend to be smaller, rifles tend to be long and designed for accuracy and power, and assault rifles are somewhere in the middle. You can carry a lot of ammunition, they can deliver it accurately. It's not as energetic as a rifle, but it is enough for combat. And just another look at the variance between things like a 22 long rifle at the left side, 9mm 40, 45s. These are your common pistol calibers that you're going to see. And then all the way up to 50 caliber, military top round. Just some more muzzle energy and context. So, we were talking about numbers like this low 1000s for assault rifles, 2000s for hunting rifles. And then as you're getting into military rounds, this is, 50 caliber, 15 millimeters. These are, substantially more, and again, designed for vehicles and that kind of thing. This is all again for context. And then back to this sort of original picture, just for, again, reference, you can see the numbers here compared to the 20,000 that you were saying before. And then if you're really curious about this, this is the railgun that they had on the battleships briefly. And you can see the muzzle energy here is now in the millions of joules, as opposed to 5 kilojoules. It's 33 million. So 4 orders of magnitude sorts of difference, and what this is a naval gun is putting out. So what does that mean? Bringing this math and physics into a clinical context. So these are the next several slides are going to be bone injuries. They all have a small bullet hole. And so we'll start with this one. So this is, a fairly large bullet. You can see there, it bounced. There's a comminuted fracture of the bone, but it's not substantially displaced. A lot of the energy actually remained in the bullet after it bounced and ended up in the muscle of the shoulder. And so this is sort of like an elastic collision. An elastic just means that energy is preserved between the collisions. So whatever is moving away from it, whether that's this initial, the thing that hit it itself, or the thing that was hit, whatever is moving carries the energy, and so that energy is not necessarily delivered into in this case the target. What that looks like when you have things of different mass. So these are all elastic collisions. The one at the bottom is what I want you to look at. Is this models what happened in the shoulder? So you have something that's relatively light going really fast, hitting something that's relatively heavy, and so again, rather than moving, the bone deformed and broke, but then the bullet bounced off and carried a lot of the energy away with it. Inelastic collisions are more like a dart than a billiard ball. And so the energy is then absorbed by the collected target. Momentum is preserved between these, but a lot of the energy gets lost as friction, heat, waste, that kind of thing. Now, taking it kind of a step further, this is thinking like in between elastic and inelastic. And this is kind of how fractures and fragmentation work. So as you start to hit multiple things, even in quote unquote elastic collisions, the energy gets spread around between multiple parts. And so you can see the model on the left. This is the blue ball hits the red and orange cluster, and they both take a piece of the energy away. That's less than if you just had one thing that it hit. Similarly, on the right, there's the dark blue ball and the 3 light balls that collect the energy, and then are spread out in 3 directions. So if you imagine that taking yet another step, this cluster of balls could be a 3D billiard ball rack. A ball comes moving in quickly from the side and hits the cluster, and then the cluster scatters, but at different speeds in different directions, and all much slower than the initial projectile. And so if you think about this, it again, in the context of the bullet coming in through the tissue, doesn't give up a lot of energy, hits the bone. The angle that it hits and the way that the bone fragments will have a lot to do with how much energy is absorbed. And something that hits in a way, as this model is showing, will absorb substantially more energy than something that hits in a way that acts more like the previous models with the bounce effect. And so here is another gunshot wound to the femur, and you can see both the bullet and the femur shattered. There is some deflection here, but now there's penetration. The bone is actually broken. It's displaced. And so this is somewhere, higher than the first one, but you're still getting some bounce effect. You're still getting some energy loss into the muscles, which is not going to do as much damage in terms of the bone. Now, to take this a step further, here's an example of a high energy round. This was a hollow point type round that hit this person squarely in the hip, and you can see the bullet itself completely fragmented and gave up all its energy, and the bone absorbed it, and you can see the degree of break, fracture, displacement, swelling, hematoma in the tissue, a very debilitating injury. The patient fell over immediately and had a very crunchy hip when we tried to reduce it. Here's another example. This is a bounce effect, but with a bullet that you can see has this mushrooming shape. It had a deformation that gave up a lot of the energy, and still a substantial amount of energy transfer. As you can see in the fracture here. Another one, this one is actually kind of on the opposite end. The bullet went through and through the bone. It was a small diameter, higher energy bullet, went through the bone and just left a hole and didn't actually cause substantial deformation and fracture. Don't see this one very often, but occasionally happens. So that's bullet holes don't necessarily represent what you see on the inside. And so take what you saw with the bones and think this can also happen with organs. So livers, spleens, stomachs, hearts, same small hole on the outside can have a very substantially different injury pattern on the inside, and that can be survivable or not survivable. The patients with the completely exploded heart and the patient with the low energy wound to the heart look very similar from the outside. Again, the second point, we'll go back to this for a second, is bullets can take strange paths and you can't always predict them from where the holes are. My old boss used to say a gunshot wound to, name a part, the leg, the butt, the arm is a gunshot wound to the heart until you prove it otherwise. And we do see that, perineal gunshot wounds with tracks that go up towards the chest and the head. Neck gunshot wounds that go in the opposite direction than that you expect them to go. A case for an example, 40-year-old, multiple gunshot wounds to his abdomen and chest. He comes in, he's tachycardic, hypotensive, and anxious. Now, as a trauma surgeon, this makes me very nervous. This guy also was somewhat obese, not somebody who was going to be easy to operate on. And as you're sitting there thinking about, what injuries happened to this guy, what do we have to do to him? Well, it turns out he's stabilized with IV fluids and he went home. The reason that happened is because the bullets behaved in a way that is reflective of the fluid characteristics of different tissues in the body. Now we see this in many patients, not just obese patients, thin ones as well. In this case, I'll show you the scan here on the next slide. The bullet forms a pressure wave, and you can think about this like water skiing, surfing, skipping a rock, where the energy in the bullet is similar to the energy in a skier as they're sliding along the water, and that allows them to use the density difference to stay in one plane of fluid versus another. This effect can also move structures out of the way. Things that have higher elasticity and tensile strength can be moved. And these things include things like blood vessels and tubular organs like the esophagus or the trachea. This scan, let's see if we can get to scroll. Okay, so CT scan is like looking up through the feet. You can see the air in the tissue. This is that patient in the case, sliding along the muscles. And then the bullet comes to rest over in the upper quadrant there. I think.
No, wait. Yeah, you gotta slow that way down. So back up.
Yeah, it'll play.
Okay. Start talking about some of the organs that you're seeing in addition to the bullet path. So sorry.
So we'll pause it halfway through. So watch down here. You see the dark area? That's air. Oops. Okay. All right. So we see some air. The air is this dark stuff, and you see air in the body too. This is air in the colon in this case. We're looking up at a CAT scan, which looks up through the feet towards the head of the patient. The back of the patient is towards the bottom here. The front is towards the top. This is the pelvis. The white is the bones. Now, as we progress through here, I want you to watch the track of that air. And so this patient got shot laterally on the right hip. The bullet passed through the muscle layer. And then you see the bullet here on the left upper quadrant. So the path of the bullet came straight, if you looked at just the holes, came straight through the patient like this. But in reality, it stayed in the tissue layers and avoided the intra-abdominal spaces. What you're seeing here, this is the spine. This is the rib cage. The little rib bones there. Stomach is here. This is the liver. This is the spleen. Again, all uninjured. with the bullet passing outside of the central abdominal and chest cavities. All right. Here's another patient with a similar effect. This was a gunshot wound through the mediastinum. So from the upper part of the chest on one side to the other. Similarly, you're looking up through the feet. This is the spine. These are the lungs to the side. You see that this air here is a pneumothorax on both sides. You see air in the muscle tissue here. This is darker area, or I should say lighter area, the denser appearing area is pulmonary contusion from the cavitary effect. This is normal lung, that's this darker gray. This is the trachea, this is the esophagus. And notice the bullet path appears to be right through the middle of the trachea and the esophagus. And I'll let this run again as you can watch the complete course of it. You can see cavitary injuries to the lungs on this side, a bullet resting in the chest on the left with a pneumothorax. Notably did not have tension physiology, normal heart here, normal abdomen. So when we looked inside, this is what we saw. So this is the esophagus, and it's bruised, but actually intact. So we noticed that he had this sort of bruising. We kept him in the hospital. He actually went home within a couple of days and did well. This is not going to scroll. Okay. But again, point being is like these patients all have things that are classically very low survival injuries. They're the bullet holes on each side of the neck, each side of the chest, each side of the abdomen. You expect to see lots of organ and vascular injury. And what happened in the first case is it stayed in the soft tissue and went outside of the abdomen. In the second case, it went literally between the trachea and the esophagus, which if you look surgically inside, actually touch each other. There's no real space between them. There's only some flimsy tissue that you can pull apart, but the bullet did that. It even going at bullet speeds, because of this wake effect, was able to pass between these without injury. And we see this with other vessels too. Portal vein, the duodenum, with the aorta. Arteries especially are thick, and they tend to have good tensile strength and recovery, so it can be moved out of the way much easier than other structures. So here's another one. And this is changing a little bit. We're going to talk a little more about energy and energy transfer with that happens because of different bullet pathing. So it's a 35-year-old, a couple of gunshot wounds to the abdomen and then some to the arms and legs. He is stable. He has pain. He's GCS 15. So he ends up going to the OR, and we find this. So we see a grade 3 liver and a grade 4 spleen, or sorry, grade 4 pancreas. So this is the pancreas. These are bullet holes in the pancreas. This is all swollen and weird looking. This is not what a normal pancreas looks like. This is the backside of the spleen that was attached to it. This is the left side of the liver. You can see the big crack in the liver. And these again were, relatively modest appearing gunshot wounds. They're fairly small on the outside, and the 2 bullets in the abdomen did most of the damage. So why was this so big with small bullets? And the answer relates to that cavitation discussion, but also to the effects that tumbling, spin, and changes in bullet path have to do with how the bullet gives up energy. So anytime you change an object in motion, again, this is another Newton's law, an object in motion tends to stay in motion unless acted upon. That costs energy. And what that means is that energy is given up into the tissue that it is reflecting off of, tumbling through, slowing down in. Tissue also has different characteristics. Again, we're not made out of ballistic jelly. The various tissues can have different elasticity, compressibility, tensile strength, and density. And all these have to do with how that tissue will react to a bullet flowing through it like it's a fluid, or how it will react when a bullet approaches it and the wave front of the bullet impacts it. Will it be pushed out of the way, or will it, be shattered? And will that tissue, if it is expanded to a big degree, will it crack or will it reform? Skin, for example, is very elastic and has a very high tensile strength. A small hole, again, can hide a lot of damage, but also it takes a substantial amount of energy to puncture the skin compared to other soft tissues and organs. We are squishier on the inside. The effect of this can be seen in patients where you see a bullet that stops just under the skin, after passing through the entire body. And that's because it's given up enough energy that while it could pass through the skin the first time, the second time it doesn't have enough after passing through all the other skin and soft tissue. Again, because these characteristics of tissue can be heterogeneous, you see different injuries. Solid organs like the liver, the spleen, the kidney, the brain are not very elastic, and they don't have a lot of tensile strength. And so these are organs that can shatter or fracture. And so when you look at things like ballistic gel, which we'll look at a bunch of these in a minute, so everyone's clear on what that is, then that can be pretty representative of what you might see in a real organ. Keeping in mind that things like the liver especially have blood vessels within them. And so while the tissue itself is fragmentable, the blood vessels inside are much more elastic and tensile. So you may have a bad parenchymal injury or tissue injury to the organ, but the blood vessels of the organ can remain intact even with very bad injuries. And this is why people with grade 5 liver injuries can actually end up being totally fine, even though it looks like a very horrible injury in person and on CT and every other sort of means. Muscle, tubular organs, fat, and then especially skin and especially arteries can be pushed out of the way, so that they are more tensile. And like we looked in the last set of CT scans, there might be bruise damage, but in a way that is not immediately life-threatening as other organs might be shattered, or as if they were injured the way that other organs are. Lung is a little bit of a special case because lung is basically a bunch of very fragile air sacs. It's very elastic. It's designed to inflate and deflate, but it is very sensitive to overstretch and shockwave. And so that's why you see things like pulmonary contusions when a bullet of high energy passes through. And again, you saw that on the scan before with those denser areas of the lung around the area of the injury. And then fat and muscle. Fat is a low density part of the body, depending on which part of the body, and muscle tends to be higher density. Again, you can see pressure waves in these things. So bullet pathing. Now we'll show you some different examples of how bullets flow through ballistic gel, and this is how people get an idea for how a bullet will behave. But again, keep in mind in a body, all the densities are different, and so the bullet's going to be even weirder. So this is standard. This is a 9 millimeters, the most common thing that you're going to see. Again, ballistic gel is just agar type gelatin that has an approximate density similar to body tissue, but it's an average sort of thing, and it's very homogeneous across the path. You can see the bullet here, it goes relatively straight. You can see the middle portion where my pointer is here. There's a very large, quote unquote, temporary cavity that collapses down. And then you have this, again, quote unquote, permanent cavity left behind. You also see a neat effect here with the little flash. That's actually a combustion effect from the cavitation. And so all that energy that was in the bullet, it stretches the spring of the tissue. And then when that collapses down, it ignites the substance in there, almost like a diesel engine does with the compression, and creates enough temperature to briefly catch on fire. In contrast, here's a hollow point. You can see all that energy gets given up relatively early, and then it sort of tumbles and stops. This particular one doesn't fragment the way that some other rounds will, but the effect here, you see all that energy being given up in the first part. And again, the idea is that this delivers that energy into the tissue that it's passing through and causes damage that way. This is a 5.56 small assault rifle round. And again, you can see the vast difference in the amount of energy given up. And so what's important to keep in mind is while this bullet itself is actually quite small, it's the same size as a 22 caliber, small gun bullet. But because it has a similar amount of energy to, again, a 7.62 round, it's about twice the energy of a handgun, but into that small bullet, the velocity of that bullet is very high. And so now you get things like tumbling and cavitary effects to a much higher degree than you would of a large bullet with the same energy. And again, you can see just the dramatic difference between that and even the hollow point round here. Shotgun, just for comparison, you see there's just a big group of little pellets. They all go in, they spread out a little bit. This is a fairly close range blast, just by virtue of them being relatively close together. I would say this is within a couple of feet. This, I believe, is a 50 caliber round, so it's a much higher energy projectile, and you see a large deformation of the tissue. You see the cavitary combustion effect. You see it even after causing this the big dump of energy that in a small fragment, the bullet largely passes through without a lot of loss of energy. And here's something just in contrast to the 5.56, the M16 round. So this is a high energy slug type round. I think this may be a shotgun slug. I can't see it super clearly, but it's a large, heavy bullet that has a lot of energy behind it. And so while the lighter bullet, you remember, and I'll show you that again, tumbled and gave up a lot of energy that way, this bullet gives up a relatively low percentage of its energy as it's traveling through, even though it has a lot to give up. It goes relatively straight, it's relatively unaltered. These are things like that are used for penetration hunting, like so big game hunting rounds and that kind of thing, or this type of bullet. And I'll show you that this is the assault rifle in contrast. Again, gives up a lot of energy, and it is nearly stopped once it comes out the other side. So it's very efficient in the amount of energy that is delivered to the target versus again, the higher energy penetrating type rounds. And it turns out this is pretty well studied, the different kinds of rounds and their classic patterns. This is from military data of various assault rifle rounds. And these are the 5.56, similar to the one that we just looked at. And then 7.62 rounds are slightly larger. 9mm 45 handguns, again, poke straight holes in things, not a lot of cavitation. Shotgun, very similar to what we saw. And then this is a hunting rifle that is similar to that high energy penetrator that, or not the last one, but the one before the last one, that gave up a lot of energy, but then kept going straight. And so what's the difference between a straight round and a tumbling one? And that's, think about like a football that is not thrown perfectly. And then think about one that's thrown really badly and how it flies through the air. A football that's thrown perfectly will go far, it'll go straight, but one that is tumbling is not able to maintain that trajectory due to the air resistance. And that's similar with the bullet tumbling through the body. In this case, with the tumbles, it actually gives up a lot of that energy and causes additional damage to the tissue that it's flying through. Tumbles are described in a few ways. This sort of precession where it's like a gradually increasing or decreasing spiral. The yaw, which is just the back and forth, and then this notation, which is about a spiral around an axis. Shotguns can look different. So the close range on the left, longer range on the right, but still not super far. They have these strange wounds. I've actually gotten calls for patients incoming that were quoted as they have 100 BB shotgun or 100 BB wounds, which was, you know, actually a shotgun, and not too inaccurate of a description. That just happened all at once. This is what it looks like if you take an X-ray. There's like, again, a lot of little pellets, and if it's at a far distance, then a lot of these wounds are not particularly damaging. They hurt and they look bad. The thing is, though, you can't really determine the depth on a plain film or even and just looking at them. So like you have to consider like how they are clinically. A CAT scan can be very helpful in this. For example, like this is a CAT scan of a patient with a buckshot or medium-sized shot. And you can see most of these ended up in the soft tissue here, but a few actually penetrated quite deep. And this patient actually had bowel injuries on the inside. And so like the difference between this and the plain film here is, you know, you get a sense of the depth, you can see what organs are injured. And so like kind of moving to that direction quickly is helpful from a diagnostic standpoint. And again, like you don't know which one is which. They all will have abdominal pain. They all act like they have peritonitis just because so much of the abdomen has been hit, it all hurts. And so you have to have a high index of suspicion for managing these.
Can you point out some landmarks on that last CT image?
Oh, sure. Yeah. So again, we're looking at a CT is like looking up through the feet. The spine is here, the back towards the bottom, the belly button here on the top of the screen. This is the kidney on the right side. Again, it's on the left on the screen, but right on the patient. This is part of the kidney on the other side. We're just not seeing it full on. This is all small intestine on the inside. This is a staple line from a previous bowel resection the patient had. These little bright spots are all pellets. So the next of the four major points is, you know, people can survive things you don't think they can and not survive things you think they ought to. This is a survivor. You can see the bone is actually healed. This patient walked out of the hospital, did totally fine. Gunshot wound across the brain, transfalcine, which again is one of those things that people quote unquote don't survive. This guy did fine. This guy also did fine. It's a open chest, open belly. We're sitting there chilling out, you know, just making sure everything is okay before we leave the room, but his heart's working okay. The bleeding has stopped. This is a resuscitative clamshell thoracotomy, which is what we mean by opening the chest in the trauma bay. This is what they end up getting. This bag over the bowel is a temporary closure that lets us just get out of the operating room a lot faster. Here's another one, case 32-year-old, 2 gunshots, hypotensive, tachycardic to a small degree. And then had this, bowel was actually eviscerated out the side of the abdomen. This is another one of those tensile effects. The patient had, you know, the bullet passed through and slowed down enough that it caught hold of the intestine, and then the wake dragged it out through this relatively small wound, which is only about, you know, a centimeter or 2 in diameter, and then left it hanging out the side. And it looks bad, right? Like, you know, guts are hanging out literally, but the guy did totally fine. We ended up resecting the bowel. We fixed the hole in the abdomen. He went home, or we ligated one of the arteries in the muscle that had been hit. And then we sent him home day 3. In contrast, and this case is still one of the ones that I like, you know, wake up in the middle of the night thinking about. This is an 18-year-old. He was playing with his friends with an air rifle in his backyard. Came in with a tiny hole, you know, BB sized in the chest, in the sternum. Was kind of being an upset, angry kid, and then lost pulses in the trauma bay. He went to the operating room. He got that resuscitated thoracotomy that we looked at in the video. We we got his heartbeat and his blood pressure back. We fixed the heart. We actually did this exact repair around an artery, just like in the book. This is his post-op X-ray. You can see the projectile actually is in the muscle of the left ventricle, and you get these little stripes or packing that we put in to help put pressure on the bleeding. This fluffiness is actually ARDS starting in the patient because he has acute pulmonary hypertension. He was in extremis so long or much longer than what his initial appearance seemed to be. And so what happened to the kid was he gets to the intensive care unit. He soaks up about 100 units of blood. His heart stops again. He starts to fail before he actually stops. We actually get him approved for ECMO, which is heart-lung bypass, because everything else was stopped. We'd stopped all the bleeding. He had one hole in him. And then he arrests and becomes unresuscitatable. We open his chest in the ICU again, but heart is exposed, lungs are exposed, it's out, everybody can see it. We're squeezing it. He went into acute heart failure and his heart went from the size of a fist to the size of a cow's heart, which is about a cantaloupe. And in the setting of being at the end of what his body had the physiology to survive. And we see this a lot. This is unfortunately of people that get their chest opened in the trauma bay. This is how a lot of them die. We actually do stop the bleeding, but it's not in time, and they can't recover. This was caused by a little pellet. It looks like this. Again, you can see the shape a little bit if you're looking right there. And to date, this is the only air rifle fatality that I've taken care of, though I know there are others that have them, but something to keep in mind. So post-op, again, bleeding stopped, approved for ECMO, rearrested, unable to survive to getting cannulated for ECMO. And cannulate just meaning we attach the hoses to his artery and vein to do bypass, and basically to give his heart a break. So if he's in that acute heart failure, if we put him on bypass for a couple of days, the idea is his heart has time to recover. It doesn't have to perfuse its own blood in the meantime, and he's young and healthy. Otherwise, it might be able to survive. So that leads directly into the last point. And again, this is the one that if you remember nothing else from even the other four things, or the other of the four things, this is the one to remember. So time saved is life saved, regardless of the injury. The less time between the time of injury and the time of hemostasis, and for a bad injury, that means surgery, and not just surgery, but stopping the bleeding in surgery, the better the patient will do. And then keep in mind, this kid, we stopped the bleeding in surgery, and he still didn't make it. The goal really an hour from the time of injury. We talk about the golden hour, and really how you measure that is time of injury to time of hemostasis, not to time of transport. It's not time of arrival to the hospital to time of hemostasis. It's time of injury to hemostasis, the whole thing. We also talk about the platinum in 10 minutes. And this is just to emphasize that while under an hour is good, the less time that you spend before hemostasis, the better the patient will do. And this has to do with this effect of physiologic reserve. And patients like this kid, this 18-year-olds, my boss also used to say, they're young kids and they're too dumb to know that they're dead yet. And so you've got time. A lot of the crazy saves that we've had, hearts blown open and stuff, and we've sewed them together and they end up walking out of the hospital. They survive because, one, they're young and they have the physiology reserve to tolerate it, and two, they get to us in 15 minutes. And so to give somebody with a otherwise unsurvivable injury a chance, or to make sure somebody with a survivable injury maintains their chance, which is often the case when you're talking about longer transport times. Expediting that entire process from your encounter to loading them to transport to unloading to deeper to briefing to the team you're handing off to. All that time counts in this time from injury to hemostasis. So what does that mean? So operative strategy, again, we're preserving physiology in that whole transport and even like their initial thing in the trauma bay. We're going to transfuse, we're going to give them fluids, we're going to try to keep them warm. High epi doses is not great. Sick hearts don't like it. It increases oxygen demand. It reduces your ability to actually like get the heart restarted later, even though it will make almost anything have a heartbeat. Honestly, if you're not physiologically full, so transfused and got hemostasis, is probably better just to do CPR. So again, priorities: controlling hemorrhage, identifying the pattern, control contamination. This is what we're thinking about in the operating room. And then we got to get out. You know, how do we get out? And so what do we mean by hemostasis? Hemostasis means put pressure on it. That's sort of step one. This buys you time. Or take it out. That's definitive. This is a busted spleen. This is a busted kidney with a bullet hole in it that we also took out. And this is holding the artery in the vein on top of it just to limit the blood flow while we are getting the kidney exposed and mobilized so we can take it out. A right kidney is a little harder than a left to get rid of. This is a liver that's wrapped up, and it's got, again, here's the liver. There's a big crack in it. This is some tissue in the abdomen called the omentum. It's a fatty organ. It's actually pretty good at acting like a bandage. So we can stuff that into the liver. It's a little bit of an old school technique, but it works. These are surgical sponges. There's some dry ones there that are sandwiched around the liver, and that's just to kind of hold pressure on it. You can see the schematic down here, a little bit occluded on the side. Here, another picture. This is another way to hold pressure on it from the inside. So this is a bullet hole that we have filled up a rubber drain with saline and inflated it like a balloon on the inside of the hole to hold pressure. It works sometimes. You can leave it in for a couple of days.
Can you point out that anatomy, please?
Okay, fine. So this is, the head is up here at what's the top. This is a midline incision. This is the right side of the patient. This is the liver, right side of the liver here, left side of the liver here. Stomach is here. This is small intestine. That's colon over to the side. So this is a hole that goes through the right side of the liver, through kind of the middle of it, where we expect a lot of big blood vessels to be, where this is going to bleed a lot, where you can't really stick your finger all the way in there and hold pressure. And so this is one way of doing it. Again, just as an example of creative techniques people have come up with to hold pressure in awkward places and what it actually takes to control intra-abdominal bleeding. Again, that some of this is like, you know, we think about holding pressure on it for arms and legs and groins and, you know, even necks, but when you're in the abdomen, there's just so much space. Oftentimes you have to be creative about how to actually temporize that bleeding. Here's another liver picture. Sorry, is there a question?
No, I just had to mute somebody.
All right, got it. Here's some other liver pictures to show the various techniques. Again, this is the right side of the liver. That's a retractor with a sponge around. That's the gallbladder peeking out. This is a liver with a bunch of stitches in it and some Surgicel, which is like a little sort of cellulose-based material that helps clot. This is a liver wrapped up in a little mesh bag to help it, like in a car crash. This is the kind of thing that we would do in order to help stop the bleeding, or frankly, in somebody with a big cavitary gunshot to the liver. Like this is the kind of thing that might help. This is, you know, we looked at the bag that was over the intestines before. This is just a formal picture of it and what it looks like. And this is really what we're doing. We're trying to get out before these things happen. Hypothermia, coagulopathy, acidosis, they all worsen each other. They all make things like vasopressors not work. They all make things like your normal physiology not work. You don't clot your blood, your heart doesn't beat very well. And getting out of the operating room before all this happens is really that key to surviving. So my anecdotal experience, and again, if you remember nothing else, transport time is king. The shorter time between injury and definitive intervention is correlated with survival every time it's been looked at. Other things designed to keep the person alive are really just designed to do that long enough to get definitive control. Even with support, you have a limit. So like you get to the operating room, we talk about that golden hour at the 1 hour mark. After the 2 hour mark, survival drops pretty precipitously. And even like young, healthy kids, if you're not out before that time period, that will start to bleed from injuries that they don't have, just surface, what we call coagulopathic or medical bleeding. There's not actually a hole there. It's just that the clotting's not working and they're bleeding out from everything. And so we want to avoid that. So again, the 4 takeaways: small holes can hide big injuries. You don't know where the bullet went. So, the bullets can take strange paths through the body. They can hit things that you don't expect or dodge things that you do expect. People can survive bad injuries and die from not so bad ones. And again, if nothing else, time saved is life saved. And if you remember that, I will consider this a successful educational talk. Questions?
Alistair, that was spectacular. Hey, everyone, I sent around the link for the sign in. Alistair, there is a question. Please talk more about epi use.
Yeah. So epi is, it's tempting, right? Like it will, I've said before that it will give a rock a heartbeat. The thing with epi is it works by stimulating, the adrenergic response, right? So it basically turns the throttle up. I think the problem with epi in, let's say, hypovolemic trauma patients is that they don't have the ability to resupply their heart with the metabolic, let's say, fuel that they are consuming by beating. And so if you give somebody that is not, let's say, resuscitated, or let's see, at least temporized hemostatically. And so that might be a cross clamp on the aorta, or it might be, I actually ligated the vessel that's bleeding. Then what happens is they do get a heartbeat, but then they they are not able to maintain it. And then whatever time you feel like you've achieved by that heartbeat, you lose on the back end, because once you get the bleeding stopped, you can't get them resuscitated again. They go into acute heart failure. They don't have reserve when they actually need it to power through the part where you've got them fixed and you got them tanked up and you're giving them some CPR to get the juice flowing. You've corrected their acidosis. You're giving them bicarb calcium, all that. Then that's the time to give them the epi, once you're fixed, once you have a place to go. If you're talking about it from a resuscitative thoracotomy standpoint. So generally, if there's a bunch of holes in the body, then we wait. You do CPR where you can. If you have no blood in the heart, then there's not a point of trying to restart it. So we do the CPR, we get the cross clamp on, we tank them up. Getting the resuscitative access can be difficult. Sometimes that means a big cordis catheter in the right atrium. Sometimes it's just several large bore IVs, depending on where we're at. But if we don't have that, and oftentimes people that don't have a pulse are difficult to get IVs in, as I'm sure a lot of you guys know. The time period there can be testing. For you're like, I want to do something, the heart's still not beating. But whether you are squeezing the heart manually or it's beating on its own, it's still not pumping blood. And so if it's not beating on its own, it's not contracting, at least it's not using up myocardial metabolic reserve. And so you still have that, to a point. Like, at some point, like without blood flow, it's not going to work, but you have a few minutes, right? And the younger they are, the longer you have. So you really want to wait until they have restored perfusion ability before giving them epi. Otherwise, the epi just burns myocardial potential before you can actually get anything out of it. And that anything is it perfusing itself, it perfusing the rest of the body, that kind of thing. You keep in mind, if you have a cross clamp on somebody or somebody has not had a heartbeat for a while, all their other organs are also like in metabolic extremis. And so it's like a transplant. If you put a big organ in and then release it, or it's a ischemic leg that you now reperfuse, all that washback is going to hit, and you got to be ready for it. And epi is often a part of being ready for it. Does that answer the question? Is that helpful?
Super helpful. Can you talk more about tranexamic acid's role in situations where it may or may not be as beneficial?
That's a good question. I think TXA makes a lot of sense in a systematic way. I think you have to have both a pre-hospital and a arrival to hospital system that is on the same page about what are you doing with it. If that's in place, then it is my impression that TXA is probably a good thing in patients with hemorrhagic shock. If you don't have that, I'm not sure that there is a real demonstrated clinical benefit. We give it empirically sometimes in people that are injured this bad because we know they're going to get lysis. Sometimes we give them Amicar if we don't have TXA, but anecdotally, I've noticed that it helps sometimes. It doesn't always seem to. In that situation, again, in the systematic way, I've seen it work. We did it in Ohio pretty effectively. Again, different trauma population, but statewide in Ohio, people got TXA for hemorrhagic shock in transport, and then second dose once they arrived.
Yeah, I think the state protocol draws notice to benefit when given within the hour.
Yeah, that makes sense.
I don't know the primary literature to support that. Other questions, you guys? What about whole blood in the field?
Huh. That sounds nice.
So
I'm sure
my take is that the medevacs, right? They're working on a blood program.
Yeah, I understand. And I believe, have it now in the ED, but it's like 2 units though. Like it's a start. I mean, I think getting any at all, I think, is helpful for building a program that will actually work. But I'm not sure we have the capacity to do or to get the big benefits from it. I think where you're going to see the benefit is these sick, super sick trauma patients that roll in with no blood, and then we give them whole blood. I think that's going to bias a lot more physiologic recovery based on the data that's out there. I'm excited to see where this goes. I don't think we have the system in place yet to really see the maximal benefit from it.
Yeah, and there's really no infrastructure, right? I mean, the storage of blood, making sure it doesn't expire, given the rare usage of blood in the pre-hospital setting, at least in our area for sure. Those are pretty big hurdles.
Yeah. Community consent is also sometimes an issue. Is this, if you have, not everyone is accepting of blood as they are of medication. I think, there's still some medical literacy stuff about like risk of transfusions that can be an issue when it comes up. All these sort of things I think will come to bear. It's a pretty complex thing to get off the ground from a pre-hospital standpoint, I think, but interesting in terms of the potential.
I do think the state police, right? I think they're actively working on a program to get blood into the field with the GO team.
Yeah, I understand there are some efforts, but I don't know the specific of who is doing it from a pre-hospital standpoint.
Another question, what about plasma cost-effective availability versus blood?
That is out of my health services understanding. Actually, Madhu Subramanian in our division is a good guy to talk to about that. He's been part of this whole blood infrastructure development, has had an academic interest in it. I'm not sure about the effectiveness of plasma pre-hospital kind of thing.
Yeah, I think, I mean, again, I don't 100% know the pre-hospital literature around this topic specifically, Brian, but I could definitely share, in my critical care resuscitation, taking Dr. Kent's patients into the ICU, those studies to demonstrate resuscitation, FFP is not something that fresh frozen plasma is not something that should be used as a resuscitation fluid. And other colloids like albumin, for example, and hetastarch, which is a protein containing fluid, also is associated with increased risk for end organ injury in trauma patient and are actually contraindicated.
I will caveat that and say, plasma as part of a balanced resuscitation, that is, trying to approximate whole blood with components,
So that's
is substantially better than just red cells alone. But if the question is like, is it FFP by itself as a resuscitative fluid? I 100% agree with Sean's comments.
yeah, the idea of, what FFP, I interpret the question to be, is FFP any easier to get out into the field in terms of the benefits and, the logistics of it? What, Alistair, what you bring up, this issue about, if you give a red cell or 5 red cells in the trauma bay, how many other yellows should you be giving? How much plasma and how many platelets do you give is an area of active research. Most fields are kind of leaning towards 1, 1, and 1, something like that. Pretty
I have a
pretty
strong
aggressive.
opinion that is the correct answer.
Pretty much back to whole blood, but in components. Great question. Okay, let's see. The pellet wound patient, a real 100 units of blood, or was that a metaphor for a lot of blood?
Not a metaphor. It was actually an underestimate. I think it was more like 110 or 120. I use that quantity of blood probably as much as anyone else does. Between us and transplant, really, I've personally emptied the blood bank more than once. At Bayview, I've done it 10 or 15 times. But it comes into a question, especially in blood shortages too, is like how many is too many? And it's a little hard to know. Like you don't really, you're not counting, like all this happens was within the course of, it's either within 2 hours or it's within 6 hours. And then they either get better or they die. That's sort of the time course. And, we try to, every time we have one of these 100-unit transfusions that doesn't make it, then that's a big discussion that comes into our quality conferences and that kind of thing. But we do try to be cognizant of the amount of this precious resource that we're using. And on the other side, it's like, if you save somebody, a lot of times these are young kids. These are, people with a lot of years left. And we do have a lot of saves because of good transport time.
Discussions, organizational discussions around, should we be limiting the number of units? And what about the risk of other people in the hospital are going to need units when, the trauma bay kind of uses up all the stores? I don't know what your take is. My sense is that those conversations don't go very far, because when you have somebody in front of you, nobody's going to stop.
But I think it's for the ones that don't make it, and this is the ones where a lot of times you either have, if you don't have the bleeding stop and they're, rearrested, not recovering, that's easier, right? It's the ones where you have the bleeding stopped and then their heart stops later because it ran out of, juice or realistically, this cardiac reserve we talk about. Those are the ones that are really hard. And it's hard to know. It's like, is it done or is it not done? Is it done or does it need, another 10 minutes of CPR and bicarb, and let's get it enough that it can restart. And then we can manage the acidosis. We can get them on dialysis. We can do that kind of thing. We can get them on ECMO, can we bridge them to one of these other more definitive therapies? And those are very difficult questions, but we do review all the morbidities and mortalities after these, and a lot of these discussions get into the weeds quite a bit. Fortunately, this isn't every day that we have a 100-unit transfusion, but it does happen some frequency.
There's a question, have you seen or is there some evidence of success with stop the bleed techniques, packing the wound, et cetera?
100%. There's more anecdotal cases than I can count of people that have life-threatening injuries that come in and now the bleeding has stopped. And it has, because it was stopped early, they didn't get coagulopathic, they didn't lose physiologic reserve. And they either go home or get like admitted for a very short stay in cases where they may have needed like, whole blood uncross match resuscitation and, prolonged ICU stays, emergency operations, all this kind of thing in the past. And since instituting these techniques, like it's just really marked how often a lot of these injuries that seem like they're a lot worse, or should be a lot worse, but then because they got packed, someone put pressure on it, somebody put a tourniquet on, like, and then the patient preserves their physiology, and then now they're relatively easy to take care of once they get to the hospital.
So there's another question. How do you decide if a pre-hospital cardiac arrest is inoperable and we should just pronounce them without transporting?
That's a really good question. So I don't want to necessarily comment on MIMS policy, but what I will tell you from when they get to the hospital standpoint is if they have witnessed signs of life within 10 to 20 minutes, and that signs of life is like, following command or moving visibly, they're breathing, they've got a heartbeat, blood pressure, that kind of thing. It's pretty lax in what that is. And they have let's say, for example, penetrating injury to the chest. Those patients often will get a resuscitative thoracotomy. Patients with
So can you do that time again? So you're saying within what time?
Let's be a little liberal with it, say 20 to 30 minutes. The guidelines have some slightly different times, but that's the ballpark.
Great. So a patient who presents, they're down, but they were seeing some evidence of life 20 to 30 minutes ago, gunshot to the chest, you guys are going to go to the OR.
Yeah, or honestly, if they
open there in the ED.
we're going to open them in the ED, yeah. That's that big clamshell thing with the beating heart sitting out in the breeze that he saw before. And what that allows us to do is, with that injury pattern, there's a high probability that it's something that we can either temporize or fix very quickly. If it is a penetrating wound to like multiple areas or like the abdomen, percentages of survival are lower, but they're not zero. So a lot of those we still might, especially if they have signs of life. So one thing we look at when they get to the trauma bay, and oftentimes the times are not 100%, and we're not really sure if what counted as a sign of life or not, but if they have a narrow rhythm on the EKG, so QRS, not like a big wide agonal thing, the rate is above 40, so not like agonal bradycardic, or they have organized cardiac motion on ultrasound. So we'll put an ultrasound on the chest, and even if it's like they don't have a pulse, but I can see systolic squeezing, it's just weak or the heart's empty or whatever, then we give those people a chance. And I say a lot of times, I think our survival rates for these are quite a bit higher than the published rates, just because I think our population has a relatively short transport time. The people with blunt trauma that arrest have a very low survival, and most people would say you shouldn't try to open their chest. Though, if it's a recent arrest, then we probably would treat them like a medical code, do ACLS for some period of time, put blood in them, see if they restart. I don't know if that directly answers your question or not. But the more recent that the signs of life were, the better their chances are. The more recent that injury was, the better their chances are.
Yeah, so penetrating trauma, any recent evidence of life, keep them warm, get to the
Get them there. Yep. Get access if you can. That helps. Saves us some time.
right, but don't over resuscitate with crystalloid.
Right. I mean, you can give them a liter of fluid, but you don't give them 15 liters of fluid.
So somebody texted, golden hour, what can a medic on an ambulance do other than rush patient to the ER? That's
I mean,
right.
I think that's really the key is you don't want to. I think getting access, like I was saying, is helpful if you can do it. I understand that doing that and trying to get to the ED fast are in competition a little bit. Either you're bouncing around the back or you're getting them in the car rather than leaving them on the ground to start the IV. And I think, if I have to choose between access and time, I choose time.
Yeah.
100%. I think if you choose between access and any other thing, I choose time,
And I think to this person's point also, I think a really good point for EMS is just to recognize that time slips by quickly,
Mhm.
right? So we think that we're moving quickly, but delays, whatever may happen. Yeah, sometimes we spend perhaps a little bit too much time at the scene, maybe lulled into, hemodynamic stability. But yeah, we need to move quickly.
Yeah. I mean, I think the thing with
We'll move
is
faster.
if you're, we lose track of time too. Like we've actually done a lot of looking into like when people lose time and in these kind of high pressure situations, and individuals are like the worst at understanding how long they've been in a situation. You want to consider like, because every minute counts on that whole perspective. Again, it is not just transport. It's not just trauma bay. It's from when they get injured to when we get definitive control of the physiology. So it's not saving individual minutes certainly benefits that. Saving seconds adds up to minutes, which certainly benefits that. So I think even little optimizations in that process of, can I get them, into the bus faster? Can I get or get on the road faster? Can I, save a minute here, save a minute there? And usually I think these things are mostly process related. It's the time between steps. It's the number of steps rather than like how fast each step is done. I think that's something important to keep in mind. So you don't want to like cost yourself multiple extra steps by rushing through a single one. But, I think if you focus on the goal of let's not do things we don't have to do, let's get them to definitive control as soon as possible. If we think they might need it, let's go and then decide on the way if things change. I think that's you want to err on the side of getting them there sooner rather than later. And don't be lulled like some of these other points. Don't be lulled into a false sense of security because somebody looks fine.
Right.
Like, I mean, obviously we have triage criteria and we have to decide who to transport and not. But like, gunshot wound to the chest, like that kid, he looked fine. He was just acting like an asshole kid until he arrested. And because especially young people, they can look totally normal for a very long time with very little blood in their body. But all that time they're burning their cardiac reserve, and all that time counts against you in terms of this golden hour thing. And when we talk about this kid that died, I mean, he had about an hour and a half transport. He lived far away. He was a little, recalcitrant. Didn't want to come, that kind of thing, and ultimately it cost him.
Wow. Ooh. That's a tough note to end on.
Sure.
Alistair, thanks for being with us. We're at the top of the hour. We super appreciate you. I suspect others can email through me if they have other questions for you or want to get in touch with you.
Yeah, happy to follow up if anyone wants to talk more in depth or other questions, that kind of thing.
Great. Super appreciate you, and we'll catch you next time around.
All right. Thanks, John.
Thanks so
Thanks.
much.